Welcome to CaliforniaCare. Today we're going to talk about pediatric anterior fractures. The reason I mention the word anterior is that majority of the time when children fall, they normally fall on a table somewhere or an object which is in the middle of the sofa or bed, and normally they hit the corner. And majority of the time they go ahead and fracture their maxilla, or the anterior region. It's between canine to canine. And majority of the cases I have seen are the incisors. They could be central incisors or lateral incisors, right or left side. Anyhow, when the child comes in, normally the parent says the child fell down and he's been crying or she's been crying, and either they lost a tooth or the tooth has been pushed in. Okay, that is totally subjective information that is coming from the parent. But what we need to do is we need to ascertain surgically and clinically to make sure that we find out where the broken tooth is, hasn't been avulsed or hasn't been pushed back into the socket. Sometimes the tooth or tooth particles, broken particles, can end up getting embedded into the lips, upper or lower lips, or even the tongue. So we have to evaluate all of these regions, and the first diagnosis we start with is the data collection. First part of the data collection was parents' information. Secondly, you go ahead and take some radiographs. Today I'll show you how to take the radiographs and where to take them. Okay, so when it comes to taking the radiographs, what we need to do is we need to go ahead and realize that the fracture is in the anterior region, and we need to take one radiograph of the tooth by using the bisecting technique to get the upper teeth. You can use bisecting technique again to take the lower teeth, and I'll show you how to use a bisecting technique. Third thing we need to do is we need to take the x-ray film and slide it into the lips, into the vestibule, and then expose the radiograph on the outside, upper and lower one also. That way you get the radiograph of the lips, just a soft tissue without the teeth being involved. So again, one radiograph of the upper lip, one radiograph of the lower lip, then one radiograph bisecting technique wise on the upper teeth, and then one radiograph bisecting technique wise lower teeth. Now in case the tongue is involved, what you do is you'll have the patient lift up the tongue, put the radiograph underneath, and have the tongue stick out. The way you can hold the tongue is wrap it up in gauze, pull the tongue out, and underneath the gauze put the radiographic film and expose it on the top. Instead of exposing your own fingers, you can have the parent hold the tongue, and you get certain idea of where if there is any embedded particle in it. Now in this case we're talking about bisecting technique. The idea is fairly simple. The film has to go flat in between the teeth, and I'll show you on a model also. And what you do is you draw an imaginary line in your mind how the film is laying flat. Then you draw an imaginary line of how the tooth that you're trying to image, what the long axis of that tooth is. Then you bisect that line in between, and you put the cone exactly perpendicular to that bisecting line. When you do that right here, then the tooth will give an image onto the film without much distortion. If you need to take a little better angle on the top and make the tooth foreshortened, you change the angle of the cone and the tooth will be foreshortened. If you need to elongate something, you reduce the angle and the tooth will be elongated. And you repeat the same thing on the bottom. That way you don't have to try to adapt the film to a narrow palate, which normally is a case in children. They have very narrow palates and you cannot get full length film standing inside. Here we have a model. Although it's an adult model, not a pediatric model, but the same way. You will go ahead and take the film and you place it and have the patient straight bite down. Once the patient bites down like that, you're going to draw an imaginary line to see where the upper teeth are going, and the film is going like that, so the bisecting line would be right here. That way when the cone comes in, it comes in like that. And you do the same thing for the lower teeth. You can go ahead and take a radiograph on the lower teeth the same way. Take a look at this line, the line of the teeth. Bisecting line is like this, somewhere in between, and the cone has to be perpendicular to it 90 degrees, and that's how you'll get that image. And when you're taking the image of the vestibule, go ahead and take the film, fold it nicely, slide it up into the vestibule, have the patient close down the lips, and then you go ahead in that vestibule, you expose the radiograph from the facial, and you can take a lower vestibule picture the same way. So here when we're looking at the total number of images, you're taking the radiograph of the teeth, upper arch, lower arch, that could be 2 radiographs. And you can take 2 radiographs of the lips, upper and lower. And in case the tongue is involved, you take 1 radiograph of that. In case the fracture is on the side, then you can take, instead of the tongue or the lips, you can take radiograph of the cheeks. And that would get a nice coverage for the patient. To recap the situation, what I would like to say is make sure that you do evaluate that the teeth you are treating are pediatric teeth. Sometimes what happens is the patient comes in and you think the tooth that is peeking through the tissue is a pediatric tooth, and you think there's a fracture there and you pull it out. Sometimes you can make the diagnosis on the fracture on the basis of simple mobility. In case of a trauma, you can have mobility of the teeth. Sometimes the alveolar process also fractures. It does not mean you extract the tooth. And I recently came across a situation in one of the dentists was going to extract a tooth, adult tooth. But she was able to take the radiograph and consult with us. And showing her, we found out that she was about to extract an adult tooth. Good thing was the patient was in pain, and she sent the patient back home with some pain medication, and she was going to extract the tooth next day. And the tooth she was going to extract was an adult tooth, and it got saved. And I'll show you a schematic of that in a second. The schematic says if the radiograph comes out like that, look at the size of the teeth. And even if an adult tooth seems to be very close to eruption, you might think it's a pediatric tooth that got stuck inside. Please go ahead and look at the measurement of the pediatric teeth that are there. Look at the measurement of the adult tooth and normally compare. Adult tooth is much bigger than the pediatric tooth. And in case a tooth got stuck in there, send the patient out home to get an OPG done. Okay, that would show you all the way to the nose. And if you do not find a pediatric tooth stuck in there, please do not extract the adult tooth. And that is the essence of it. At the same time, I want to reassure you that our team at CaliforniaCare is available to answer any of your questions anytime, even via WhatsApp, or you can call us, or you can email it to us. And these consultations are totally free of charge. We would not charge you anything. What we want to do is promote good healthcare, good diagnosis, good treatment planning, and good execution of treatments to save people trouble. Remember the oath we took, I shall do no harm. Second part is I shall do good. We want to stick to that. Thank you. Please feel free to send a WhatsApp message on this number, +1 714 244 9239. You can call us in Pakistan at this number, and this is our address. And the address we have is actually CaliforniaCareDental@gmail.com. The email address again is CaliforniaCareDental@gmail.com.